a 63-year-old lady, and she had said her diagnosis is cord compression with severe myelopathy. Again, an interesting case because I always have these fun, interesting cases. So this lady was with her friends at the mall, walking around, and she fell. And she fell, and she really couldn't move her arms and legs. She was really tired, so her friends decided to put her in a wheelchair and then continue walking around the mall and shopping. But she really couldn't lift her arms. She could, lift her legs, but her arms were very, very weak. And they decided at the end of a 4 or 5 hour shopping outfit that they said, hey, she's still not feeling well. Maybe we should take her to the emergency room. So they took her to the emergency room. And this was her scan. So she was severely myelopathic, and on examination she had 3 out of 5 in her upper extremity. So she was barely anti-gravity in her uppers, and she was weak in her lowers. Multiple falls in the past, severe gait instability, and she had urinary retention. Now what makes this, to go back a slide, what makes this more challenging is that she's a chronic rheumatoid arthritic, she's on chronic prednisone, and she's hypertensive. So her bone quality was really just abysmal. So again, looking at her, I decided to go front, back, I'm going to go back a slide here, sorry for the advance. So her compression, and when I look at these cases, I try to simplify it. I say, where's the compression? What are we going to do? If the compression is in the front, I like to go from the front. If the compression is the back, I like to go to the back. If the compression is the front and the back, then depending on what you can achieve on one side, then you add the other. Again, I try to simplify my life and make things easy. So for her, because she had the spondylolisthesis and she had a significant gibbous pushing into the cord with cord signal change, particularly at the C4 and C5 level, I thought the best thing for her was a combined approach. And again, due to the very, very poor quality of the bone, I thought that supplementing from the front and the back would maintain the fusion and help prevent her from having a pseudoarthrosis or loosening of screws and need for additional surgery. So I ended up doing monitoring her, putting in traction, and doing the anterior C4 and 5 corpectomy. I reconstructed her with an expandable cage again, and I used, again, her bone quality was so poor. I used minimal amounts of it. It was so poor. It was almost like the OsteoAmp sponge. So I packed the expandable cage with the OsteoAmp sponge and a tiny amount of endogenous bone. And then I flipped her over and did a posterior laminectomy, and then I fused her from C2 to T1 and locked her in. And again, posteriorly, I also used OsteoAmp sponge as well as some OsteoAmp granules, as well as some autograft from her laminectomy. So this just kind of highlights the importance, or highlights what the fusion can do and what a fusion looks like. On the left, you see her immediately post-op. It's a very dusk appearance of bone material within the cage itself. And this is a 14-month post-op CT. You can see just the amount of hyperdensity that's occurred throughout the cage. She fused throughout, both anteriorly and posteriorly. So again, in a 2-level corpectomy with a patient who's on chronic prednisone, weak bone, cord injury, cord signal change, she's returned to almost full trip now, walking without any assistance, and has a tremendous amount of fusion, and she's reconstructed. She's kind of achieved a relatively normal cervical sagittal balance. Now again, she's a rheumatoid, and this is now, it's been probably about 3 years since I've seen her. She's maintained her neurologic exam.